You are listening to Medscape's In Discussion series on colorectal cancer, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Benjamin Schlechter. Dr. Schlechter is a senior physician in gastrointestinal oncology at the Dana-Farber Cancer Institute. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Benjamin Schlechter, and welcome to Medscape's In Discussion series on colorectal cancer. Today, we're discussing ctDNA and colorectal cancer with Dr. Pashtoon. Dr. Kasi is an oncologist and researcher at Weill Cornell Medical College and the New York Presbyterian Hospital. At Weill Cornell, he's also the director of colorectal cancer research, as well as the precision medicine director for the liquid biopsy research at the Englander Institute of Precision Medicine. Before we dig into our topic, Dr. Kasi, I'd like to hear a bit more about your path to becoming a GI oncologist.
For me, I would say my path has always been punctuated by the mentors that came along the way. My parents are both physicians, so we grew up in an atmosphere and environment of healthcare folks being around. Our mom had her clinic in the house per se, so I would sometimes room patients for her and get her teed up. So, growing up in a household of doctors, we were definitely inclined towards the medical profession, but didn't know that wanted to do oncology till during my training at University of Pittsburgh, where one of the first random electives that I got assigned to do was in oncology, where I had an opportunity to work with colleagues and mentors and teachers who were treating patients with vaccines and clinical trials in the clinic. We often, as residents and medical students, don't see the part of oncology, which is purely often only our patients. So that's where my interest in oncology started. And then my training for oncology was at Mayo Clinic, which has been the hub or the mecca for a lot of GI oncology innovation and trials. So it's hard to be at Mayo Clinic and not be inclined by the GI oncologists who have paved the way for a lot of things that we do here today.
Yeah, it's amazing how education and environment sort of informs the direction of physicians. And I think it's a great point for thinking about training programs and getting trainees into the clinics with oncologists and how we practice medicine, as opposed to just sort of the crisis management of inpatient care. You've been among the most important and sort of forward-thinking advocates for ctDNA and colorectal cancer in the United States. And I'll be honest, I'm one of the slow adopters here, and you've begun to convince me as I've listened to what you've had to say at national meetings and what you've written. I want to start with some basics here. Can you just tell us a little bit about the different approaches for ctDNA testing? What are the advantages of different tests?
Just a side comment before I talk about these tests. For me, I would say the early adoption actually started as a patient need. As part of my first faculty positions, I was at a place in an institution where access to tissue was not a simple, straightforward, streamlined process that we were used to seeing at places that are well-oiled machinery, so to speak. So I came across many patients that, when I would talk to them about repeat genomic testing or repeat tissue biopsy, over the course of all the treatments over the years, that they would rather do anything and were open to treatment and other things, but not one more procedure, which is where I had heard about some of these blood tests that maybe could tell you this information. I didn't know if it was something that was worthwhile, or was it sensitive or specific enough. But because it started off as a situation, as a patient need, a question that a patient asked that, could I get a blood test instead, is what prompted me to see one of these first results, and I would say early insights into experience with some of these tools. And along these tools, important, especially now more than ever, is the fact that there are different kinds of liquid biopsies. That some purists don't like the term liquid biopsy, but I think it's actually more relevant now than ever, because there's not one type of liquid biopsy. As one of our colleagues calls it, there's a lot of tumor trash that's detectable in the bloodstream. So it's not just circulating tumor DNA or ctDNA that makes a liquid biopsy. There is circulating tumor cells, there's exosomes, there's RNA. Every time you turn around, there are different types, from metallomics to phagocytomics, things that could be looking at a cancer through a different lens. So broadly speaking, right now, with the method which they're looking at circulating tumor DNA, which is the farthest on the liquid biopsies that we have in the clinic for colorectal and some of the other cancers, they're divided into what we call tumor-informed assays versus tumor agnostic or plasma only, or tumor uninformed assays. For the former, you need a piece of tissue to be sent simplistically to make a barcode for the patient for that tumor, that instant in time. And then you look for the same barcode or signal in the blood. Whereas for the latter, the plasma only or tumor uninformed assays, you just need the blood sample or the plasma to look at a panel of said genes or said signature.
Excellent. Thanks for that clarification. That's actually a great point. Also thinking about the inflammatory environment, which is increasingly important. So a number of trials have been presented at major conferences, and some have even been published in this field. And a lot of the data is really focusing on early stage disease where defining the role of chemotherapy has been a challenge in colorectal cancer. So you presented the bespoke trial at GI ASCO this year. Can you tell us the background on this trial and a little bit about what you found that you think is most clinically meaningful for us?
Bespoke was one of the first prospective, largest studies, at least in the United States to date, looking at a tumor-informed, as we were talking about, different types of liquid biopsy assays, more so kind of moving up the journey of a patient with cancer to earlier stage disease or this minimal residual disease or molecular residual disease, or this term that we have borrowed from our hematology colleagues in terms of MRD, so to speak, is the situation, at least for colon cancer, and it's probably going to be different. It's a flexible definition depending on which cancer or which therapy or which tumor type are we talking about in the setting. But for colon cancer, for the most part, the situation that it's trying to provide additional insights to is in patients with high-risk stage 2 or stage 3 cancers. These are patients who are not necessarily cured by surgery alone. And there is a question of mop-up chemo, so to speak, for 3 to 6 months, depending on each individual setting. So the question or the idea that often comes up is that we don't have a tool to monitor who's cured, who's not cured. We don't have a tool to monitor progress on the particular mop-up treatment. Often our patients, when they see the surgeon who informs them that they're cured of their cancer, they got everything out, they often wonder, why are we seeing a medical oncologist? And when we often talk about chemo to mop up any residual cells, it's kind of like a invisible concept that some patients have a very hard time wrapping their head around. For the first time, we have a tool potentially with somebody who's not cured. The circulating tumor DNA or liquid biopsy shows positive results, as in not the term positive in terms of persistence of disease or still presence of cancer DNA in their bloodstream. Whereas a negative result means that the ctDNA or circulating tumor DNA, they didn't find anything, that potentially those are the ones who may be cured. Simplistically speaking, we'll talk more about what a negative result means and the limitations and challenges around it. But this is what a readout potentially in the perfect world could lead to somebody who could be spared of the toxicity of chemotherapy, the ones who are ctDNA negative. And maybe, we need to come up with better strategies or more aggressive therapies or other novel therapies for the ones who are not cured. Those are the ones who are ctDNA positive. A few years ago, you couldn't even say the word circulating tumor DNA or liquid biopsy before being interrupted or something that people didn't want to talk about, let alone do a trial. So this study kept in mind the current temperature at the time, where it didn't mandate the treatment as per the protocol, because even some of the trials that are right now that ctDNA is an integral marker where you have to make decisions based on the results of that. I don't think we were prepared for that a few years ago. What it did differently was, compared to some of these retrospective studies that looked at prospectively collected samples where the patients and providers never knew what the results were, this was the first trial that was providing the tumor-informed assay results real time to the patients and their treating oncologists, and was capturing also the decisions. If the decision to treat or not treat was changing based on the results before the results came back and also when the results came back.
Excellent. And this is a big study. I remember scribbling down the numbers as you were talking at ASCO. More than 1,700 patients enrolled, 6% positivity in stage 2 disease, 22% in stage 3. And that kind of speaks to our clinical experience where there's a difference between the stages and the outcomes.
Absolutely. And that too, talk about like how much enthusiasm there is in the field. This study started and finished during the pandemic. As you know, all of us had to face a lot of challenges to keep any kind of research or trials open, let alone start and finish a trial. So over 71 patients per month over a couple of years. So this study enrolled at record pace at 33 sites in the country. In some ways also kind of shows the power of liquid biopsy to democratize or decentralize trial access, because this is a simple blood work that needed to be sent with the block. This could have been done at any place that had the capability of simplistically FedExing a blood sample.
We also have the Galaxy results out of Japan. So the Circulate CRC study in Japan, there's the version in the US. Galaxy was published by Dr. Daisuke Katani in Nature Medicine last year. And this also was an observational study, but it looked at stage 2 all the way to stage 4 disease and did a single check at 4 weeks, used that as a prognostic biomarker. And pretty much it was the best prognostic biomarker. The only thing that came close was probably BRAF positivity. How does Galaxy and its findings compare to Bespoke? And what else can we learn from the combination of these two?
As you pointed out, I would say Galaxy was just the version that was done in Japan. Our colleagues in Japan were ahead of doing the study and had published the initial findings in Nature Medicine. And at ASCO GI this year, they provided with more update with over 3,000 patients now prospectively accrued. It was using the same assay, same company, same tumor-informed platform. In many ways, I find it very hard to look at some of these ctDNA studies and know which one is which, because the results are very much in concordance with each other in terms of you see the ctDNA positive curves touching the x-axis that if you don't do anything about it, those are the ones that pretty much uniformly have recurrence at 2 years benchmark, which is the time for most of the patients with colorectal cancer to have a recurrence if they don't have an intervention after the positive result, meaning it's going beyond prognosis to, as one of our colleagues refers to it, it's like a marker of not necessarily prognosis or just a prediction of treatment. It signifies persistence of disease. The half-life of ctDNA is a few hours to a few days. So if your test is unfortunately positive today, it just means that you still have the disease, or in this case, colorectal cancer, still in your body.
There are two presentations at ASCO this year. We had the Dynamic study and also the Cobra, the GI005 study. So let's start with Dynamic. So this was presented by Dr. T, and this was a trial done in Australia. This enrolled patients with rectal cancer, not just colon cancer. These had to be T3 or T4 patients, or those were node positive and who did not have a clinical pathologic complete response, rather. And this randomized patients 2-to-1 to ctDNA guided adjuvant therapy versus clinical judgment guided adjuvant therapy. And in the ctDNA guided group, those who were ctDNA positive had 4 months of either FOLFOX or CAPOX, or in some cases of fluoropyrimidine alone. And those who were ctDNA negative were observed. And that was against those where clinical judgment was done and ctDNA was not tested. This trial had a number of important findings. Number one, there was reduction in the use of adjuvant chemotherapy in patients who had ctDNA testing. And the recurrence-free survival was the same at 2 years. This was a non-inferiority result, which is really interesting. But there's some things that struck me. In particular, patients who were T4 rectal cancer, but ctDNA negative, actually still did pretty poorly. And how do we interpret that population where the ctDNA positivity clearly is bad news, but what do we do with the ctDNA negatives with negative prognostic findings? And how does this inform our treatment decisions here?
So in many ways, the answer to your question lies in your question. I feel that that's where the field needs to embrace ctDNA not as a separate variable in a separate silo or in a different room. It has to be taken into context in the existing patient that you're talking about. So one of the great examples of the same study that you're referring to, the Dynamic 2 from Dr. T, one thing it did, which is I think we need to learn, is, of course, positive you see across the board. Everybody does, unfortunately, not well. They do have poor outcomes. So it's easier to kind of come up with what should be done. The fallacy is more so in the ctDNA negative. And one interesting thing about Dr. T's study is they actually grouped ctDNA negative patients into two groups. One was your ctDNA negative, but also node negative. So kind of like favorable outcome, as you were referring to. So those are the ones that you could plainly observe. The ones who were kind of in the middle, like you said, who had ctDNA negative, but poor prognosis, in this case, they defined prognosis by node positive residual on the post-chemo rad imaging. They actually didn't mandate that you should observe. They actually let the physician and the clinician decide. You and I, every day, if we put the ctDNA out of the equation for a second, when you look at a stage 2 high-risk patient or even a stage 3, when we reviewed these findings at our weekly tumor board, we never just talk about this is a stage 2 patient or stage 3 patient. We talk about the T4, as you mentioned. We talk about the clinical context of perforation or obstruction. We talk about subtle things like, differentiation to lymphovascular invasion to tumor budding and things that, are still kind of fancy from a pathology or teaching standpoint, but may or may not have any clinical relevance, but are all things that we factor into the decision-making about what we may or not want to do for each patient. And with a line or statement starting in the NCCN guidelines for stage 2 saying that the first thing we should talk to our patient is the limited benefit that we provide. With that thing in mind, if you have a variable that I would say is the strongest prognostic, if not one of the strongest prognostic variable across multiple studies, why wouldn't you not integrate that into your decision-making as well? And also, going back to last year's the Dynamic study, the year before, that also showed that ctDNA-directed management didn't have any inferior outcomes, but it's important to realize that, again, it halved the use of chemotherapy, but it also kind of stood up to our decision making as well. Granted, we treated twice as many with chemo, but we achieved similar outcomes. So the clinical decision or judgment that you and I make on a daily basis based on our training, experience, expertise, leaning on our colleagues in surgery and pathology to guide us through the process, I don't think we can work without them. There's no reason why ctDNA should be viewed in isolation. If you had a very low risk stage 2 patient that you weren't planning on, let's say, doing treatment, the test comes back as positive, well, that's a very important finding. You may want to change your plan or reverse your decision or revisit your treatment strategy, as opposed to, somebody who's ctDNA negative. Again, in the right clinical context right now, it's a great time to be enrolling in some of these trials. I remember a few years ago, as we opened the Circulate US study, a plug-in for a prospective study that's right now open in US. And again, our colleagues in Japan are ahead of us on that study as well, is randomizing patients to observation, for example, in ctDNA negative. But that study, for example, also does not allow a T4 negative patient to even enroll in the study. So again, it should not replace our clinical decision-making. It should help complement it. And I think only if we use it in that scenario is where we would not fall prey to these ctDNA negative but high-risk clinical situations. And also, before we order any test result that's not just true for ctDNA, but I would say for any testing strategy, is what are you going to do with the results of the assay? So if there are clear expectations with the patient and the caregiver and the team about how you're going to use the assay, that's where I think there'll be less confusion or not disappointments about when the assay results come back.
One test is never going to be the only thing that informs us. And so it's helpful to put this in context and think of this as a powerful tool, but certainly not the only tool that we're using. It's always nice when you get a very clear answer, but those are uncommon, especially in GI oncology. On the flip side, we had the Cobra study, the GI005 from NRG, that was presented by Van Morris. Like other studies, this saw a positivity rate in stage 2 of about 5 to 6%. And here patients were randomized to a ctDNA guided therapy versus observation. And what's interesting to me about this study is not so much the outcome, because like everything else, it shows that we can give less chemotherapy in some settings, and that's important. But this was a 2-step process from the NRG group. A lot of patients who were ctDNA positive then cleared, and this ultimately led to a meeting futility of the pre-specified endpoint, and so it didn't proceed. So how do we fit this in context, and what are the dynamics of ctDNA when it's positive versus when it clears?
I think it's an important question, again, pertaining to like the methods that we use for ctDNA as well. One of the things that is true for this particular study is the use of a plasma-only assay, half of which is also dependent on metabolomics as well as mutational signatures without knowing the tumor's mutational status. Similar note are these early detection assays as well. Some of these are multi-cancer early detection assays. And, they talk about these patients who are positive. It would be very interesting and curious to kind of learn who are these patients who are positive and quote-unquote cleared without treatment. So there is a question that you're probably detecting a signal that may or may not have been cancer. This world of metabolomics, epigenomics, it's fascinating. It's very intriguing. But in terms of knowing and making sure that nothing else that's non-cancerous or a different type of cancer or a different type of inflammatory process is not causing an overlapping signal, I think would be helpful. There are not many reports out there. We actually ourselves, our group has published a couple of reports. In one case, we were looking for a colon cancer signal, and we stumbled upon a patient with liver cancer and a head and neck cancer. So maybe cancer signals were overlapping, leading to false positivity. In another scenario, we had a patient who was ctDNA positive and on a trial was going to get maybe more chemo and kind of disappeared into thin air and then showed up a couple of months later and wanted to go back to treatment again. And when we tested him, the test cleared, like you mentioned. The only thing that happened between time point 1 and time point 2 was, well, did you do anything? Did you have any treatment or what? And the only thing that happened between time point 1 and time point 2 was he had a very high hepatitis C viremia of over 1 million, and he got a highly effective curative anti-hepatitis C treatment between type 1 and type 2. So again, this is anecdotal, but a couple of informative reports in similar settings where in one case, a different cancer was leading to a signal. I think again, it's not about the assay. I don't want this to be interpreted as if one assay is stronger than the other. I think it's about the understanding and the context. And going back to the clinical scenario, if somebody with very low risk cancer comes back with a signal, is it worth verifying on another test or doing another complementary approach before you act on it versus somebody who's high risk where you shouldn't even trust a negative signal regardless of whichever company's signal it is? I think we'll fall prey less to these fallacies in that scenario. I would say it's similar to like our experience with, next generation sequencing over the years. CHIP as a detection of mutation of something in the blood wasn't an entity till recently, not too long ago, even though some of these blood testing and genomics have been around for, more than a decade. So we knew over the years and learned by doing mistakes that there are things that not everything they need to act upon. I think for ctDNA and MRD assays, as well as early detection assays, I think there's still room to learn. I wouldn't interpret this as a negative study. I know that it has confused the field somewhat. I would say it's just an ongoing learning that we need to figure out. And I think it would be helpful to kind of see from follow-up. I know from the Pegasus study that used a similar study that's from our UK colleagues, they were looking at some reports of who are these folks who are positive but then haven't recurred despite treatment versus spontaneous clearing, so to speak. So it's an area of active investigation and very intriguing in terms of what does it mean.
So let's actually talk about Pegasus. That was presented last year at ESMO by Dr. Lenardi, and that also was a ctDNA study. Again, there's some nuance, and that's why I was careful to say we met futility in 005 as opposed to it was a negative study, because I think it's a study we learned a lot on. But in Pegasus, ctDNA was used to de-escalate chemotherapy as opposed to escalate chemotherapy. So patients with high-risk stage 2 disease and stage 3 disease who were ctDNA negative received 6 months of capecitabine, and those who were positive had 3 months of capox. The other interesting intervention here was that patients who remained positive with ctDNA then crossed over from capox to FOLFIRI. And what we saw in Pegasus was that ctDNA seemed to clear with chemotherapy, and that showed improved outcomes. But ctDNA could clear with chemotherapy. And that raises some interesting questions for me. One of them, that reminds us that chemotherapy works in the adjuvant setting, which is great, and we know it. But it also points out or may remind us that chemotherapy works in the palliative setting. I continue to wonder in Pegasus, where we don't have adjuvant data supporting FOLFIRI in multiple prior studies, are we taking these high-risk patients and delaying the inevitable with an alternative chemotherapy, or are we actually clearing micrometastatic disease using these interventions, with all caveats in place that this is really a small study that was hypothesis generating?
But I think, bringing up an important point, it does signify the ctDNA as a dynamic variable in terms of something that's not necessarily just a death sentence. It could be converted to negativity during adjuvant chemotherapy. In some ways, that's what adjuvant therapy is for. And then this switch to FOLFIRI, or in some ways, sometimes I call it the adjuvant plus setting or MRD plus setting. So the setting between where you're still not cleared from ctDNA but do not have radiographic disease, that could a first-line intervention help clear metastatic disease? I would say, I would take a step back. I would say, ctDNA, maybe it's not just about less chemo or more chemo. I think there's only so much improvement that we can do on the chemo aspect of things. I think it's a perfect ground in terms of, pairing it with all these innovations and advancements that are happening. So some of the trials that we are doing in this MRD plus situation, adjuvant plus, it's not just about more chemo. It's about, for example, for the MSI high that, for example, might have just gotten chemo, maybe those, 10, 15% in stage 3 should be getting early initiation of immunotherapy to the 4, 5, 6, 10% HER2. Maybe it's time to switch to anti-HER2 blockade. For the BRAF, we have some open alliance studies and some of the other concepts, again, asking about bringing a study earlier. A lot of the ongoing vaccine studies are using this opportunity where this is probably the time when you have the least amount of cancer in the body because you're only picking up micrometastatic disease. One other thing that I wanted to kind of mention in the bespoke study that we kind of showed, again, this is prospective but anecdotal, is we picked up about 100 recurrences. 40% of those were oligometastatic. Now, again, if it was pancreas cancer versus some other cancer, you could argue, but colorectal cancer, we know, even in our patients who present with stage 4, but organ limited or few sites of disease, that the intent of treatment is still curative in intent. Can ctDNA, for example, not just about switching to FOLFIRI, at least till we get better treatments around or trials. This is a good situation or place to do more trials. But could you, for example, increase the proportion of patients who can get oligometastases directed therapy with resection, ablation, Y90, you name it? There's so many local regional modalities. And we know from our surgical colleagues and our experience that it may not be just about delaying the inevitable, that there are a proportion, all of you, us have patients in our clinic who not only presented with metastatic disease, but are survivors and folks alive years out. And the proportion of those patients is increasing over the years. So maybe ctDNA can help increase those patients because it's not uncommon to have a situation where, well, I wish we had known about this cancer earlier. How often do we hear that statement at a tumor board meeting? So as one of our colleagues sometimes mentions that ctDNA is a solution that's looking for the right problem or an answer that's looking for the right question. So I don't think it's about the assay. At least we're going beyond, I would say, corroboration of validation of the assay. Again, there are some nuances about metabolomics and plasma-only assays. Still, overall, I do think they provide a lot of value in terms of quick turnaround time, results back within 7-10 days. Not all cases can have tumor-informed assays, and about 10-15% of the time, tissue is not sufficient or present. So I think the perfect scenario would be a composite or having both lenses to view the MRD situation for each patient. But this is something that is here to stay, something that can be integrated into your toolbox, into your decision making.
Yeah, I appreciate the ambition there. It is consistent with this moonshot idea that with better testing and better investigation and better trials, that we can do so much more and help so many more. So we're joined today by Dr. Pashtoon to discuss circulating tumor DNA and colorectal cancer. And we had a wide-ranging discussion going from the prognostic value of ctDNA in some of the studies like Bespoke, which he presented at ASCO, as well as the Galaxy study and Circulate CRC in Japan and the United States, and the power of ctDNA to prognosticate, to tell us that there is cancer present on a microscopic level. We talked about some of the different assays that exist that can be tumor-informed and tumor-agnostic that may have slightly different outcomes or maybe just need more investigation, and reviewed some of the therapeutic intervention trials like the Pegasus trial presented at ESMO and GI-002, the Cobra study, also presented at ASCO this past year. And, it remains to be seen how far down this path we can go, how many different targets we can follow. One of the criticisms in the past has been that ctDNA was spooky music and we couldn't change the outcome. It was like the background music in a scary movie. And it seems increasingly the case that ctDNA is giving us information, helping us understand ways to escalate chemotherapy in the right setting and ways to de-escalate cancer therapy in the right setting to focus on the best possible outcomes for a population of patients and also for individuals. So thank you again for joining us. I'm Dr. Benjamin Schlechter for In Discussion.
Thanks for listening to Medscape's In Discussion Colorectal Cancer podcast series with our host, Dr. Benjamin Schlechter. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on colorectal cancer.